Warm good afternoon to everyone. I'm presenting a case of 15-year-old girl referred to our institute with a history of heavy menstrual bleeding for the past 1.5 years and the mass protruding through the vagina for past 3 months. She had underwent polypectomy twice from the local hospital in the past 1.5 years with a history of similar mass coming from the vagina. On local examination, there was a fleshy, friable, grape-like polypoidal lesion seen protruding through the introitus of size approximately 6 into 5 centimeter. MRI done showed an endometrial polyp of 5.9 into 3.2 into 3.3 centimeter arising from the fundal region. She underwent polypectomy. The upper part of the lesion was muscular. The histological report rendered the diagnosis of embryonal rhabdomyosarcoma Botryot type. IHC was positive for desmin and myogenin. The possibility of conservative surgery preserving the uterus was discussed in the tumor board. Since the origin of the polyp was from the fundus of the uterus, the decision was type 2 radical hysterectomy. Pelvic lymphadenectomy was deferred considering the sarcomatous origin and the probable morbidities of the procedure in young girl. The final histopathological report was embryonal rhabdomyosarcoma invading superficially into the myometrium, extending into the lower uterine segment and cervix, approximately 6.5 into 6.5 into 2.3 centimeter, with a clearance of 0.8 centimeter from the serosa. There was no parametrial involvement, no lymphovascular emboli. ER/PR was positive and CD10 strongly positive around the glands. She was followed with PET scan, a metabolically active, ill-defined soft tissue thickening in the pelvis along the surgical bed, and a subcentimetric right external iliac node suspicious for residual lesion was present. She was started on VAC regime and 11 cycles completed. Rhabdomyosarcoma is a rare solid tumor in the childhood and adolescence. It's of 3 types, embryonal, alveolar and pleomorphic. Out of it, embryonal has a better outcome. The patients with the rhabdomyosarcoma often presents with a bleeding and found to have mass on pelvic examination. Microscopically, the typical finding is a campium layer. If hypocellular areas with edematous or myxoid matrix are predominant, the tumor may be confused with a benign polyp. According to the clinical staging system, female genital tract is a favorable site and non-metastatic tumors are considered stage 1. No standard treatment is available and the recommended strategies are mostly based on the treatments of RMS of the other sites. Take-home messages: polyp in pediatric and adolescent age group should raise an early suspicion of rare pathology. Malignancy should be excluded. Decision for fertility preserving surgery or radical hysterectomy should be decision of a multidisciplinary care team, as embryonal rhabdomyosarcoma most commonly presents in the second decade when decision may be doubtful. And the overall survival is, 5-year survival is 82%. Thank you.